Hello, my name is John Green. I'm one of the pediatric anesthesiologists here at University of Kentucky. This is part of the Anesthesia ITE Keyword Review for 2022. This presentation is specifically on pediatric physiology. Our first keyword is fetal circulation, specifically anatomy. It's important to understand that fetal circulation is considered a parallel circuit. And what is meant by this is that both ventricles provide systemic blood flow and contribute to the cardiac output. In fact, by 38 weeks gestation, the right ventricle is dominant, providing almost 60% of the cardiac output. This is accomplished by three significant shunts. So we have, just as a review, we have relatively oxygenated blood coming via the maternal uterine arteries through the placenta. It comes through the placenta into the umbilical vein, where at the liver we have the first shunt, the ductus venosus, which allows for approximately 30 to 50% of this blood to bypass the liver and go directly into the inferior vena cava. This blood comes from the inferior vena cava and it goes into the right atrium, where there is some mixing of this relatively oxygenated blood and relatively deoxygenated blood that's coming from the superior vena cava, which we'll discuss in a minute. But the vast majority of this blood is directed via the eustachian valves across the right atrium and into the second shunt, the foramen ovale, where it goes directly into the left atrium, to the left ventricle, out the ascending aorta, and perfuses the head and upper body. Then we have the return of relatively deoxygenated blood coming from the superior vena cava down to the right atrium, where again there is some mixing of blood here, but the vast majority of this blood is directed into the right ventricle, out the right ventricular outflow tract, into the main pulmonary artery, where the vast majority of this blood is directed via our third shunt, the ductus arteriosus, into the descending aorta, where it perfuses the mesentery, the renal system, and essentially the middle and lower body. Now, transitional circulation is not necessarily one of the keywords, but I do think it's important to understand what is occurring at birth. So you have two main processes going on that affect the fetal circulation at birth. You have an increase in pulmonary circulation and you have an elimination of the placental circulation. So when the baby begins to breathe, the lung expansion expels fluid from the lungs and establishes a functional residual capacity within the lungs. This increases the alveolar partial pressure of oxygen and decreases the alveolar partial pressure of carbon dioxide, which greatly reduces the pulmonary vascular resistance. This in turn decreases the right ventricular afterload and increases the left ventricular volume load. Simultaneously with the clamping of the umbilicus, you have the elimination of the placental circulation, which decreases the right ventricle volume load and increases the left ventricle afterload. And so we now have the postnatal circulation and the closure of these shunts that we discussed. So the ligation of the umbilical vein decreases the portal pressure and causes a functional closure of the ductus venosum within 1 to 2 weeks, and then the ductus venosum becomes the ligamentum venosum by 3 months. The second shunt, the foramen ovale, functionally closes once the left atrial pressure exceeds the right atrial pressure. And in most, this functional closure becomes a permanent closure. However, it is important to understand that this foramen ovale may remain anatomically patent during infancy or even beyond. And then finally, the ductus arteriosus is closed due to an increase in the arterial PaO2 and a reduction in the circulating prostaglandins following the separation of the placenta. the ductus arteriosus is considered functionally closed within 12 hours, and it becomes the ligamentum arteriosum in 2 to 3 weeks. So with the final postnatal circulation, we now have a parallel circuit that has become a serial circuit, where we effectively have two pump systems. The right ventricle is supporting the pulmonary circulation, and the left ventricle is supporting the systemic circulation. Our next keyword is fetal hemoglobin and oxygen transport. So remember that the fetus is dependent on the maternal oxygenated blood. And as I said earlier, this is relatively oxygenated blood. What I mean by that is the blood in the umbilical vein has a PaO2 of around 30, considerably less than the normal 80 to 100 seen in adults. So the way that this provides adequate oxygenation and perfusion to the fetus is because of fetal hemoglobin, and that the fetus has predominantly fetal hemoglobin. Remember that normal adult hemoglobin, hemoglobin A, consists of 2 alpha and 2 beta chains, whereas fetal hemoglobin has 2 alpha and 2 gamma chains. As we can see from this bottom picture here, in utero, the fetus produces very little beta chains, but vast majority of gamma chains. Now at birth, this ratio changes, and the fetus produces less and less fetal hemoglobin because of the less amount of gamma chains that are produced, and more adult or hemoglobin A because of the increase in beta chain. Now, fetal hemoglobin has a higher affinity for oxygen with a P50 at a PaO2 of 20. So as a reminder, the P50 is the PaO2 at which hemoglobin is 50% saturated with oxygen. In adults, or hemoglobin A has a P50 around 27, whereas fetal hemoglobin has a P50 around 20. So in essence, the hemoglobin dissociation curve is shifted to the left in the fetus. It's also important to understand that the fetus also has lower levels of 2,3-TPG, which further shifts this hemoglobin dissociation curve to the left. So since even though that the umbilical vein has a PaO2 of 30, this is enough to saturate, or at least mainly saturate, the hemoglobin and provide adequate perfusion in the fetus. Our next keyword is persistent fetal circulation. Persistent fetal circulation is when there is a sustained and severe increase in pulmonary vascular resistance that leads to persistence of right to left shunting. The shunting can be either the foramen ovale via a patent foramen ovale and or a patent ductus arteriosus. In this condition, you have cyanosis and hypoxemia, which is refractory to 100% oxygen supplementation. Clinically, this may be seen with a well-perfused preductal circulation and a relatively poorly perfused postductal circulation. So you might see relatively pink right upper extremity and head, and a relatively cyanotic looking left upper extremity and lower body. Causes for persistent fetal circulation include physiologic stressors such as hypoxia, hypercarbia, acidosis, hypothermia, sepsis, severe hypotension, or excessive airway pressures. Essentially anything that drastically increases pulmonary vascular resistance. Associated conditions include things like meconium aspiration syndrome, congenital diaphragmatic hernia, maternal use of NSAIDs, etc. The treatment for this condition is first and foremost to identify and treat the cause, but this may require adjuncts that decrease the pulmonary vascular resistance, such as inhaled nitric, sildenafil, or even ECMO. Our next keyword is cardiovascular physiological differences. So differences with the neonate and the adult. First difference depends on calcium. So the neonatal heart is dependent on extracellular calcium for contractility, whereas in the adult, The adult has a better developed sarcoplasmic reticulum, which allows a rapid release and uptake of intracellular calcium. The neonatal heart is primarily dependent on carbohydrates and lactate as the primary energy source, whereas in adults, the primary energy source is free fatty acids. The neonate has a much better tolerance to ischemia compared to the adult. Additionally, the neonatal heart has a decreased ventricular compliance, which limits its response to increased preload. Essentially, the neonatal heart is primarily dependent on heart rate alone to increase cardiac output because it is already operating at the upper end of the Starling curve, whereas the adult is much better able to adjust stroke volume in response to increased preload, Starling curve, and or an increased afterload. The final difference is that the neonate has an immature autonomic nervous system with a relatively unbalanced parasympathetic dominance, which reaches maturity within a few days, compared to the sympathetic nervous system, which reaches maturity by early infancy. Our next keyword is maximum estimated blood loss calculation. You may also hear it as allowable blood loss calculation. This is just unfortunately one of those things that you have to memorize. The formula is maximum estimated blood loss equals the estimated blood volume times the initial hematocrit minus the final hematocrit divided by the initial hematocrit. You can also use hemoglobin instead of hematocrit if you prefer. So what you do is you decide what the final hematocrit is. That is the lowest allowable hematocrit for this patient. We typically would utilize something like 21%, which would correspond to an hemoglobin of 7, or you could use 24%, which would correspond to a hemoglobin of 8. And that depends on the child's pathophysiology, the nature of the surgery, etc. So whatever that lowest allowable hematocrit is, you subtract that from their current or initial hematocrit, and then take that number and divide it by their current hematocrit. And then that would give you a ratio that you would multiply by their estimated blood volume, giving you their maximum estimated blood loss. For example, you have an initial hematocrit of 30. Your lowest allowable hematocrit would be 21%. So 30 minus 21 is 9. 9 divided by 30 is 0.3. So you would multiply that patient's estimated blood volume times 0.3, and that would give you the maximum allowable blood loss. The table below shows the estimated blood volumes for patients depending on their age. Keep in mind that these are kind of averages. Depending on what source you utilize, you may get some different values or ranges, but this is typically what I use. So a premature neonate has an estimated blood volume of around 95 milliliters per kilogram. If it's a term neonate, it's 85 milliliters per kilogram. Infant would have 80 mils per kil, child has 75 mils per kil, an adult male has 70 mils per kil, and an adult female has 65 mils per kil. Our next keyword is pulmonary physiological differences. Should be noted that there's actually quite a few sub-keywords under this entire category. And so I've kind of highlighted the things that are most important to take away from this. So some of the differences, the first differences involve breathing mechanics. Remember that neonates are obligate nasal breathers, and they have poorly developed intercostal and accessory muscles. So they primarily use their diaphragm for the work of breathing. Now, here's another keyword. The diaphragm has type 1 and type 2 fibers. The type 1 are the slow twitch fibers, which help prevent fatigue. Unfortunately, the preterm infant has less than 10% type 1 fibers in their diaphragm, and the term infant has only 25% compared to 50% in adults. What this all translates to is that neonates and infants are more easily fatigued. The next main difference is in compliance. neonates and infants have a decreased lung compliance and an increased chest wall compliance. What this means is that the increased chest wall compliance offers little to no support for the less compliant lungs. This leads to increased work of breathing, and it makes the airways more prone to collapse and atelectasis. The third difference is in oxygen consumption. So normal adult oxygen consumption is about 3.5 milliliters per kilogram per minute. You can see that the neonate has almost 3 times this at 9 mils per kil per minute. And then you can see the infant is 7, small child is 6. And finally, at school age, the child reaches the adult values of oxygen consumption. So this increased oxygen consumption leads to more rapid desaturation. And anyone who has struggled at all with an airway on a neonate will rapidly appreciate this rapid desaturation that can occur. Lung volumes are also a little bit different. The total lung capacity is decreased in infants. It does reach adult values by 5 years old. Now, the tidal volume and the functional residual capacity on a milliliters per kilogram basis is essentially the same throughout all ages, with one important caveat. The FRC is similar during normal breathing. However, general anesthesia, apnea, and the supine position change this in the infant and the neonate and decreases the FRC under these conditions to only 10% of the total lung capacity, when the normal is 50% of the total lung capacity. That's a very important thing to remember. FRC is decreased in infants and children under general anesthesia, especially if the child is apneic and or supine. Another lung volume that has changed in infants and children is that they have an increased closing capacity. Actually, this closing capacity can surpass the functional residual capacity. What this means is that this can lead to atelectasis and airway collapse even with normal respiration in infants and children. Final difference that we wanted to discuss is airway resistance. Children less than 5 years old have higher airway resistance, mainly in the peripheral airways, but it's almost 4 times higher in adults. 4 times higher than adults. What this means is that even relatively mild inflammation, edema, or secretions can severely obstruct their airways. Neonatal apnea physiology is our next keyword. Just some reminders about control of ventilation. This occurs through central and peripheral chemoreceptors. The central chemoreceptors respond primarily to changes in the PaCO2 and pH, and the peripheral chemoreceptors usually primarily respond to changes in PaO2. Apnea is defined as cessation of breathing for greater than or equal to 20 seconds. It can be obstructive or central. Obstructive apnea primarily occurs in the pharynx, since this is the most collapsible portion of the upper airway, and it's usually treated with position changes, oral or nasal airways, or CPAP. Now, central apnea is also known as apnea of prematurity. This occurs to 3 different things. 1, a relatively immature nervous system. 2, there is an impaired hypoxic ventilatory response in neonates. There's kind of this biphasic occurrence where hypoxia will initially stimulate respiration, but sustained hypoxia then depresses their ventilation. This will last for about a week in term neonates, but it may persist for 4 to 6 weeks in preterm neonates. Finally, preterm neonates can also have impaired hypercapnic ventilatory response. Central apnea or apnea of prematurity is treated with caffeine. It's also treated with nasal CPAP, high or low flow nasal cannula, and nasal intermittent positive pressure ventilation. Another important thing to remember is that these infants are at risk for postoperative apnea, especially if they have a post-conceptual age 50 to 60 weeks or less. Additional risk factors include low gestational age at birth, anemia, another one that's commonly tested, hypothermia, sepsis, and neurological abnormalities. In fact, here at University of Kentucky, if it is a preterm, any preterm infant coming for surgery that has a post-conceptual age less than 60 weeks is required to be admitted overnight due to their high risk for postoperative apnea. And any term infant coming for surgery who is less than 50 weeks post-conceptual age also is required to be admitted overnight. Our next keyword is neonatal cyanosis differential. I'm not going to go through all of these things on this slide. This is certainly not an all-encompassing. The main things that I want to point out are the four major abnormalities that can cause cyanosis in the neonate. First, you have airway abnormalities, choanal atresia, laryngomalacia, things like that. Anything that impairs ventilation can cause cyanosis. This can be due to a neurological insult such as hypoxic ischemic encephalopathy, or it can be due to meconium aspiration syndrome, diaphragmatic hernia, anything that's going to impair ventilation. Thirdly, anything that impairs oxygenation, such as bronchopulmonary dysplasia, VQ mismatch, cyanotic congenital heart disease. And then finally, anything that would impair perfusion, so things such as hemoglobinopathies like sickle cell or sepsis. Our next keyword is dead space in pediatric circuit. As a reminder, dead space is the portion of the tidal volume that does not participate in gas exchange. This includes both alveolar dead space and anatomical dead space. Anatomical dead space in a normal breathing child includes everything from the nose and mouth down to the terminal bronchioles. Now, when a child is intubated, you have the contribution of apparatus dead space to this anatomical dead space. And the way that this contributes is it allows mixing of inspired and expired gases. So we typically use a circle system that utilizes unidirectional valves. So only at the Y piece and distal to the Y piece, so up here at the Y piece and distal to that, contributes to anatomical dead space. Very important, at the Y piece or distal. And actually, if a median septum is used in the Y piece, it actually further decreases this dead space. But now this also includes this area here as well as the ET tube. Down here, I have shown these are dead space adapters that are sometimes used in pediatric patients. I haven't seen a lot of these here, but these are things that can help decrease the dead space. So here we have a regular adapter. The ET tube comes on this end, and then of course the vent circuit is on this end. You can see the difference in this dead space adapter where this area here is closed in. You just basically have a very narrow tube. So this basically cuts down on additional dead space. So your ET tube would go on this end, your circuit would go on this end, and then your end-tidal line would attach to here. This is the other side of this, and you can see this goes to a 3.5 tube, this goes to a 3, and this goes to a 2.5 ET tube. So speaking of ET tubes, pediatric ET tube size is our next keyword. Again, another thing you kind of have to memorize. The easiest way is to remember if they are 2 years age or older, you can just kind of use the down and dirty calculation, age divided by 4 plus 4, and that will give you your uncuffed ET tube size. Uncuffed ET tube size. If they're less than 2 years, you can use this table here, weight-based, and then term neonate would be a 3.5 uncuffed, and these are generalizations. it's important to realize this is for uncuffed ET tube size, and we typically utilize cuffed ET tubes these days in pediatric. So if you're going to use a cuffed ET tube, then you should downsize by half. So if your uncuffed ET tube size is 4.5, if you're going to use a cuffed, you would use a 4.0. You should also consider downsizing for certain patients, such as those who have subglottic stenosis, Down syndrome, which are also prone to subglottic stenosis, Marfan syndrome, which typically have a narrow glottis, things like that. I also included this little short calculation for an estimated ET tube depth, which is ET tube size times 3. So for instance, if you're using a 4.0 ET tube, 4 times 3 is 12. So roughly 12 centimeters at the teeth is the depth of insertion. Again, that is an estimation. You should always listen to lung sound to make sure you have bilateral breath sounds. Our last keyword is thermoregulation and warming techniques. So some of the thermoregulation differences in neonates and infants, they have an increased surface area to body mass ratio, especially with the head. This results in increased radiant heat loss. They also have less dermal keratin content, which leads to increased evaporative heat loss. They have a thinner layer of sub-Q fat, which leads to increased conductive heat loss. They also have a relatively small mass and immature musculoskeletal system, so they have very inefficient shivering thermogenesis. In fact, they rely primarily on non-shivering thermogenesis due to the metabolism of brown fat. As far as shivering, it is also important to remember that general anesthesia effectively blunts this shivering thermogenesis, not only in children, but also in adults. So as far as warming techniques, first and foremost is a warm OR. I'm a firm believer in that pediatric patients should have a warm OR. The younger they are, the more important this is. I've got down here at least 80 degrees. If it's a neonate, it needs to be closer to 90 degrees Fahrenheit in the room. Essentially, if you and the rest of the staff are not uncomfortable, it's probably not warm enough for the child. Things that can also help after warming the room is the radiant warmer, seen here to the right, also affectionately known as the French fryer. You can use forced air warmer like the bear hugger or a circulating water heating blanket. You can use plastic sheets or bags like Ziploc bags. You can use a fluid warmer, a vent circuit humidifier warmer, and then heat packs are also very helpful. And don't forget about transport. Anytime you're transporting from the NICU, you should have heat packs to keep them warm on your trips from NICU and then back to NICU. Okay, that is the end of the keywords for this presentation. These are references that I've utilized. If you're interested in additional references, feel free to come see me and I can kind of point you into some more potential references.